Thank you for watching the World Community Magazine's Hour of Power Live on Facebook with your host Edward McQueen and April Garner Davis.
Something tells me we're live. Anyway. Good evening to our audience this evening, and welcome to the program. All of our programs are special. I started to say we have a special program, but they all are special because we try to bring you the best in terms of health articles and issues that we think that the community needs to stay focused on. Good evening to you, April.
Good evening, Brother Edward. Good evening, everyone in the viewing audience. How are y'all tonight?
They're fine. They're fine. I think everybody's doing well, except for, a number of deaths we've been having in our city that's been bringing some sad, notes to our town. I just wanted to highlight that because of a number of people who've departed from us.
This is a tough time of the year. Seems like around the holidays, there's, always a lot of bereavement that, people have to deal with and experience. And so we definitely send out our condolences to families who are experiencing that right now, and, hope they can find some peace and comfort as they go into the holidays.
Yeah, absolutely.
Mm-hmm.
And sometimes, we have sicknesses, and sometimes people have accidents, stuff like that. But we just want to dwell on this evening, April, something that the promotion had highlighted on, and that was diabetes, and we're calling it an epidemic. If you look at it very carefully, and with our guest tonight, who's going to take us further into the program, you can see why it's called an epidemic. Okay, and its rapid growth. It is growing rapidly, especially in the black neighborhoods, in black areas, I believe. It's probably worldwide. I saw some articles some time ago indicating that was the case. So, having said that, April, we in our latest edition of the magazine, I'm sure a lot of people have seen, and that is worldwide. We had an introduction to the type 2 diabetes. That maybe some people didn't know about, okay? And it asked the questions, what is diabetes? What happens if you don't treat diabetes, and how type 2 diabetes is managed. And we're going to get to some of this because I think we have the proper person tonight to really tell us about that. At least, I get some of the best information whenever I go to see him anyway. So, talking about none other than Dr. Winston McIver, Jr., and good evening to you, sir.
Hello. How are you all doing?
Yeah, great, just great. It's great. April and I are very glad to have you on our program. We look at your knowledge whenever you're dispensing it on. You've been on a number of times. At least I've seen good feedback. Okay, so you must have a lot of patients who look at you, who go to you there, and Doctor, do you agree with the topic that we're saying, that it's almost an epidemic, that diabetes is almost an epidemic, type 1 or type 2? I don't know.
Definitely, and I'll get into some of those numbers as well to talk about it. But I'm glad to be on as usual. It's kind of hard to tell April, the mover and shaker, and Brother McQueen. It's kind of hard to tell you all no. And certainly Sister Joella. It's all about Sister Joella. So make sure you tell her I said that. Okay.
She's listening. She's listening. She's looking. In fact.
Yes.
Yeah.
But yes, certainly an epidemic with diabetes, and we'll get into a little bit about talking about some talks about diabetes.
Yeah.
Talking about the prevalence, meaning how common it is, how much it affects the healthcare system, and I'm talking about primarily in the United States now.
Right.
But this is a worldwide
worldwide
epidemic. But the numbers, facts, and figures that I'm going to give are going to be primarily in the United States. So let me first start by saying, in medicine, you know, a lot of times the term.
Can I stop you a second?
Yes.
We got people who never met you, never because we're worldwide, okay, it's definitely nationwide. So did you like to kind of I know do a little bit more than introduce yourself? That
okay.
Your practice in
okay.
Overy
Right.
County and stuff like that.
I can certainly do that. My name is Dr. Winston McIver, and I'm a native of Conway, South Carolina. Graduate of Conway High School. Go Tigers. I'm a graduate of Morehouse College in Atlanta, where I got my degree in pre-med and psychology. I went on to Meharry Medical College, where I was a graduate there. And then I went on to do my internship and residency at the University of South Carolina in the Department of Family Practice and Sports Medicine. I did a fellowship at Case Western in Cleveland. And when I finished all of that, I moved back home in 2000. I practiced with a multi-specialty group for 6 years, and I opened up Walker Primary Care, where God graced me to be able to open a practice, build a building, and we've been going here for 18 years. So I've been a physician.
Really appreciate you.
Yeah, I'm glad to be back, glad to be home. I've been a physician for almost 30 years. It's hard to believe that. And I've seen a lot of it then. Well, I'm also the athletic medical director and head team physician at Coastal Carolina University. So I do that as well with all the sports, all 19 sports, 575 student athletes we have over at Coastal. So that's another thing that I do. But
you're the main physician there?
I'm the athletic medical director. Yes, we have an orthopedic side and we have a primary care side, but there has to be a physician that kind of oversees the whole program, and that's what I do.
Right.
Yeah. Traveling with the team and all of that too.
Yeah, even when they're losing.
How?
Even when they're losing.
Yeah, we're struggling right
Brother
now.
Edward, that was kind of a low blow, brother. Wait a minute.
But if we can get this win on Saturday,
that'll put you over the hump. Yeah,
we'll be bowl eligible. But basketball is going on right now too, and the teams, particularly the women, are doing really well right now. The men are doing good too. New teams, but they're doing really well. Right. Doing really well. So I'm proud of them.
Yeah, great. Yeah. So go ahead.
So I'll have to give this disclaimer too. And a lot of times, in medicine, the term is thrown around expert in this, expert in that, expert in this. And I never proclaim myself to be an expert in anything. Although some of my patients will disagree with me on that, I don't proclaim myself to be an expert in anything. But I can tell you this, in the 30 years of doing this, I don't know very many people that know diabetes better than me. And I'm not just saying that to be, a braggart about it. I'm saying it because I'm not only a physician who treats more diabetics than anybody around here, I am a diabetic. Mm-hmm. So I'm not just talking to you about what I read. I'm not just talking to you about what I was tested on an exam. I'm talking to you about what I know because I am that. I am a diabetic. So the latest, the greatest, the newest, I'm going to know about it because I'm trying to live as long as I can live as well as keeping my patients healthy as long as we can keep them healthy. So I'm not just speaking as a physician when I talk about diabetes. I'm also speaking as a diabetic, okay, with a long family history of diabetes. So whenever we talk about diabetes, the goals in mind for a physician that treats diabetes is early identification. That's going to be very key because there's certain risk factors, there's certain family history, family genetics, certain things that will lead this person to be more likely to be a diabetic. So early identification is very important. Second important is appropriate management. Not every treatment is for everyone. It's not cookbook medicine, so you have to tailor the treatment based off of the patient, and you have to meet them where they are to a certain degree. Okay, but you have to have the appropriate management. The second thing is reducing morbidity. That's reducing disease and disease progression and the complications that can come with it. Reducing morbidity. And the fourth thing we want to do is reduce mortality, and that's reducing death as a result of diabetes. So early identification, appropriate management, reducing morbidity, which is reducing disease, complications and progression, and reducing mortality, which is death, which is associated with diabetes. So that's the goal. And if there's not a physician that's not trying to do that and that's not their aim, then that's not a person you should be seeing for diabetes.
Yeah.
Okay?
So before you go on to your next step, how is that linked to kidney failure?
So one of the potential complications of kidney disease is renal failure, kidney failure. The most common cause of dialysis in the United States in adults is because of diabetes. So that's one of the potential complications that can happen if diabetes is not managed appropriately and adequately. I'll tell you something, one of the first patients that I had when I moved back home said something to me that was really interesting, and I knew I had a lot of work to do at that point. The patient came to me and they said, well, you know, I know that in X number of years, I'll be on dialysis because everybody in my family is on dialysis. In other words, they thought that a normal progression of diabetes is dialysis, and that's an abnormal progression. Just because you have diabetes doesn't necessarily mean you're going to develop kidney failure, but it is the number one cause of dialysis in the United States is diabetic related complications.
When you let it go for a long time without
when you let it go for a long time, you're not taking it seriously. You're not taking your medicines appropriately and timely. But there are some medicines, and I'll get into that a little bit later, that have been created that actually helps slow down kidney progression, kidney disease progression in diabetics. Right. And we'll talk about that when I get to the treatment options section. But we'll talk about that.
Dr. Matt, before you get to the treatments, so once a person is diagnosed with diabetes, and I know that there's two types, 1 and 2, right? About how long does it take for treatment to actually take effect and be effective? Because I think that some people think that, as soon as I receive this diagnosis and, whether it's, I don't know what you would prescribe for it, but I start taking my medication, my blood sugar is going to immediately return to where it should be. And that's not always the case. No. So is it just a case by case basis, or is there some scientific evidence of how long it should take for your blood sugars to start to stabilize?
Well, it is a case-by-case basis. It really depends on at what state the patient comes to the physician. In other words, I had a patient come in to see me today who had been having symptoms of diabetes for 9 months. And he finally came in to me today. He got some blood work done a couple days ago. I got an A1C on him. And we'll get into A1Cs in a minute, but that's the 3-month average. That helps physicians know how to gauge the treatment and where the person's at that particular time. And again, he had been dealing with this for a while. So it will take the medicine some time to kick in to get it down. It could be.
What kind of symptoms did he say he was having?
Well, he was going to the bathroom a lot. He was going to the bathroom a lot. So one of the symptoms that patients will come in with are a cluster of symptoms. We call it the 3 Ps. Polydipsia, meaning they're excessively thirsty. Excessively thirsty. They just got an appetite. They just drinking. Just can't get quenched enough. That's called polydipsia. Polyuria. Doc, I'm getting up to the bathroom and I'm peeing 8 to 10 times a night. Doc, I'm peeing 15, 20 times in a day. That's called polyuria. And then the 3rd P is called polyphagia. They just got a voracious appetite, just eating. Those are the 3 Ps. Now, not everyone will have all 3 Ps, but most people usually will have polydipsia and polyuria, where they're just drinking and peeing and drinking and peeing. Doc, I don't know what's wrong with me, man, but I'm getting up to the bathroom to pee. I peed 12 times last night.
Well,
Those people should be screened for diabetes.
Well, could that person have got that confused and thought maybe he was having prostate issues? Because that's one of the prostate symptoms also.
Yeah, so they could, but usually if it's if it's diabetes that's just poorly controlled, out of control, you're going to be peeing a lot more than if you have any prostate issues.
All right. Okay. Right.
Mm-hmm.
So, Dr. Mack, I know that there are some people who also, you mentioned those 3 symptoms, but they may even see weight loss or weight gain. Am I correct? Okay.
Usually it's weight loss. So
usually it's weight loss. Okay.
Whenever we talk about it, so you're right. I'm going to go back to something you said a little earlier. There are two main types of diabetes. Type 1 is usually diagnosed in kids or in youth. That's only 10% of people with diabetes. Those people, their beta cells in their pancreas do not produce insulin. So those people have to go on insulin. That's their treatment. Tablets aren't an option. They have to take insulin. That's type 1. Type 2 diabetes, which is 90% of diabetics, they usually are developed as adults. And usually it's overweight adults, but it doesn't always have to be overweight. It could be a strong family history of diabetes, but that's usually diagnosed in young adults or adults. Mm-hmm. Now, the signs are what the physician sees. Some of the signs that I see when patients come in to make me think about diabetes are cuts that won't heal. Doc, I've had this cut on my leg and it won't heal. You know, once upon a time, cuts would heal real fast, but now this cut's been here for a month and it still hadn't healed up. Or, you know, when I used to do GYN and take care of women's GYN issues, it would be recurrent yeast infections. Women are coming in and they're just having these yeast infections, and that can be a sign, a tip-off that the person has diabetes. Also, skin infections, rashes that just keep popping up, boils and things like that just keep popping up that, you know, are harder to treat as well, too. That can be related to it. Another thing is when we do urine checks on patients, we see sugar or glucose in their urine. So those are some of the signs that we see, what the physician sees. Some of the symptoms: weight loss, unexplained, fatigue, tired, run down, no energy, vision changes, the 3 Ps that I talked about. Those are symptoms. Those are things that the patient feels. So signs are what the physician sees. Symptoms are what the patient feels.
Wow. Well,
And yeah, really. And so I think that a lot of our viewers, or just, you know, people in general, don't really understand how severe a high blood sugar reading can be. And I'm sure you're going to impress upon everyone that, you know, control diabetes definitely is a life-threatening condition.
Right.
And and so tell us a little bit more about that and what the technical term is for high blood sugar. I think it's hyperglycemia.
Hyper meaning high,
Mm-hmm.
hypo meaning low.
Right.
Right.
And I'm very interested in this topic tonight because I too am diabetic and I've experienced a lot of some of the symptoms that you talked about. And I think the first sign for me actually showed up in my vision, a significant sudden change in my vision. And it was detected that, okay, your blood sugar is high, and even the reason why it was elevated was, really interesting to me. But there are times when if my blood sugar is not balanced or, not where it should be, there's just a general ill feeling that comes with that. And I'm always cautious about it because, especially in the night hours when you are about to go to sleep, turn in for the night or whatever, and you may be experiencing some things and you're not quite sure of what it is, but yet it could be connected to diabetes. It can be pretty scary. So, Dr. Mack, what would you say to anyone who may be experiencing any symptoms that may even lean towards a diagnosis of diabetes, or if they're living with an individual and they're experiencing some symptoms and they haven't been tested yet? What would you say to them as far as, seeing it happening and knowing that something is wrong? What's one of the first things they should do if they think that somebody's going into like a diabetic episode of any sort?
Well, so the first thing to do is convince them to see a physician regularly. So that's the first thing. The second thing is if they're having what we call acute changes, or they may be having some mental status changes, then they need to probably go right to the emergency room, because there's a condition called ketoacidosis where folks can get into an acidic state, which can be life-threatening. So those patients, if they go into DKA, what we call DKA, diabetic ketoacidosis, they're in the hospital and they're getting aggressive IV fluids and they're getting insulin through the IV that help try to get these sugars regulated so that way it doesn't do any permanent damage to the brain, the kidneys, the heart, or any of the other vital organs in the body. Yes. One thing I want to mention too, whenever I do these talks, is I always talk about the toll it takes and the prevalence. So in the United States, it's estimated that about 16% of adults have diabetes. 16%.
That's a lot.
Of those 16%, 11% have been diagnosed and 5% are undiagnosed. In other words, they're walking around with diabetes and don't even know it. Now, they probably know something's not right, but they haven't gotten a diagnosis of diabetes. Men have a slightly higher prevalence of diabetes than women. There's also an alarming fact that about 116 million Americans are pre-diabetic, which means they've got some labs that are putting them on what we call, quote unquote, borderline diabetes. That's more than 8 in 10 adults with pre-diabetes are unaware of their condition. So 8 out of 10 don't even know that they have it, or that they are pre-diabetic, in other words. So a lot of folks walk around with high blood sugars and don't know it. And some people don't want to know it. Some people just don't want to know it. They don't want to go to the doctor. They don't want to be given that diagnosis.
So if they're pre-diabetic, what can they do to stop it right at that stage?
Well, they can look at their dietary intake. They can cut down their carb, starch, sugar intake. They can do weight reduction. They can exercise more. They can drink more water. They can try to do things to get into a healthier lifestyle. Mm-hmm. Right. Also, it's estimated that the medical costs and lost wages of people with diabetes is about $413 billion a year. That's twice as much of a medical cost compared to people that don't have diabetes. Another fact is between 1990 and 2024, 1990 and 2024, the prevalence of diabetes has gone from 7% to 16%. From 1990 to 2024, it's gone from 7% of the population to 16%. And an even more alarming stat is by 2045, it's estimated that 780 million people will have diabetes. That's 1 in 8.
So
by 2045.
In 24 years, if I heard your stat correct, it doubled?
Yeah, in 24 years, it more than doubled. It went from 17 to 16%. From 7 to 16.
To 16, more than double. So, I can only guess what could, be attributed to that. I'm sure it's, when you think about foods that are available for people to eat, lack of access to, healthier food options. The foods are made with a lot of preservatives and sugars. If you look at even, seems like any soda if you consume that, probably the first 3 ingredients are all about sugar. So do you think that people's diets are the reason for this? At least is one factor, or what do you think?
Diet is a factor. Lack of exercise is a factor. More sedentary lifestyle is a factor. More obesity is a factor. The types of foods that we eat, a factor. Stress, a factor. So all those things are factors. I don't think it's any one thing that can explain it all. I think it's multifactorial, but those are some of the most common factors that are involved with this explosion of diabetes.
Okay, we have a question before you go on, Dr. Mack. Thank you so much. When is the patient at risk for complications like heart, kidney, and vision problems?
As soon as they're diagnosed. So in other words, that might sound kind of like a slick answer, but the truth of the matter is once you get diagnosed with diabetes, you should get regular labs done. You should go get your eyes checked at least once a year, because the most common cause of cataracts in the United States is because of diabetes.
Whoa.
The most common cause of blindness in the United States is because of diabetes. The most common cause of amputations in the United States is because of diabetes. So this is a multi-organ condition. It's not just an endocrine condition. It's not just dealing with insulin. It's dealing with the effects, the fact that when your sugar's up, it creates an acidic environment inside the body. It's what's called atherogenic, which means it makes the inside of the blood vessels sticky, which can lead to more plaque forming in the arteries in the carotid artery, which can lead to a stroke, the arteries in the heart, which can lead to a heart attack, the arteries in the legs that can lead to decreased blood flow and amputations.
Wow. And we have another viewer who asked, how about genetics?
There is a genetic component to it. So if your family, if you've got a strong family history of diabetes, you should be getting checked.
Absolutely.
You should be getting checked.
That's, from what I've read, research that I've done, this kind of stems back from slavery, because of our diet, right, which was thrust upon us. I mean, we couldn't get any other of the so-called good. I'll just start with the meats, okay, and so that, I guess that is kind of like fathered into the genetics over 200 or 300 years, or 400 years, like that.
Part of it's that, and part of it's we ate what mom and them ate. We ate what grandmom and them ate. Right. So I mean that's a part of it. And that also, we see that a lot with high blood pressure as well. So it's very important to get labs done, even if you're not a diabetic. You should see a physician, whoever, once a year at a minimum, once a year. So that way you can get labs done, labs checked, so we can see exactly where you are in that spectrum.
But our parents and foreparents, I mean, they didn't have. It took money to go to get a checkup, right, to a doctor.
It did, but if you think about it, McDonald's wasn't really around back in the day. Not picking on McDonald's, but Burger King wasn't back in the day. These places weren't back in the day, back in the the 20s and 30s. And so again, the urbanization, the fast food, the eating on the go, that wasn't an issue back then. You ate what mama cooked and grandmama cooked, and if you didn't eat it, guess what? You were gonna probably go to bed hungry.
And then too, think about lifestyle. I mean, people truly work. They worked the land. They worked, they were outside more. The sedentary lifestyle wasn't really a thing for us as a people. Right. We were working the fields and backbreaking work from sun up to sundown. And so for the most part, it's like, once we kind of relax that kind of lifestyle, and like Dr. Mack is saying, started eating more of the ready-made foods versus cooking our own. I'm sure all of those things. Because the question about genetics, I think, is really interesting. And I don't know how far back genetic studies actually go, Dr. Mack, but, if like, when was, do you even, I'm sure but when was like the first time they said we have scientific research on diabetes? Did it happen in the 60s, the 70s? Was it just in the past 30 or 40 years? Because
that's a good question. I used to know the exact answer on that, but I would probably say within the last 60 years.
Last 60 years.
So,
and it may be longer than that. I don't have the exact date on it, but it's been that. But each year, each decade since then, it's been more and more that we know about diabetes, more and more information on how to treat it, which really kind of gets to the next part of what I was going to talk about, and that's how we diagnose diabetes. So the person comes in with these symptoms, the physician sees these signs, we go ahead and order a panel of labs. Now, specifically talking about diabetes, 3 fasting blood sugars higher than 126. That's what I use. 3 fasting blood sugars higher than 126, or any one fasting higher than 200. That's diabetes. Now, you know, there's an A1C that's then done once you have those numbers, and that then determines, you know, what you need to do as far as medications, how aggressive to get, and that kind of thing. The A1C is an interesting and a unique tool that we use. It's based off of the life of a protein on a red blood cell. The average life expectancy of a red blood cell is between 90 to 120 days. That's why we can use the A1C to determine within a 3-month interval what your sugars have been running. And the A1C in a diabetic should be less than 7. If it's in the 6s, that's even better. If it's in the 5s, that's even better. But our goal is to get it less than 7. Okay? Yeah. If it's not there, then we'll have to maximize therapy and do what we need to do. Talk about diet and exercise, talking about other ways to get these blood sugars and these A1Cs lower. Right. When we look at the A1C, then we look at, okay, what are the treatment options? The first treatment option that you try to do with diabetes is diet and exercise. But there's some people, when they come in with an A1C of 14, they're not at the diet and exercise. They're at needing medication. So your ultimate goal is to try to get this person to lose weight, to exercise better, to eat better, to get that A1C down, to hopefully getting them off of some medicines to help them get back to the diet and exercise. Now, I'm going to make this statement, and it's kind of controversial, but I'm going to make it because this is the way I feel.
You're on WCM Live.
Huh?
You're on WCM Live.
Gotcha. This is how I feel. Once you have diabetes, you always have diabetes. Really? I've heard people say, oh, I've been cured of diabetes, or I don't have diabetes anymore. No, you may not be taking medications anymore, but you still have diabetes. In other words, what it means is you still, even if you're off medicines, you still got to watch what you eat. You still got to watch what you're doing. You still got to look at the diet and exercise as treatment number 1. I'll tell you a story. When I was a resident, one of the first patients I ever had was a diabetic. She lost a lot of weight. She did really well. She listened to what I asked her to do, and I was able to take her off of medicines. I told her, you still have diabetes. She didn't hear me because she knew that she was off of the medications. 6 months later, I admitted her to the hospital, and she had DKA. Because when she came off the medicine, she thought she didn't have diabetes anymore. So the point I'm making is once you're diagnosed with it, you have it. Now, you may not always need medications. Now, there's some doctors that don't believe that philosophy, but if they don't, their patients can get into trouble just like this one did that I had. Thank God she lived, she made it, but it's a point to be made that once you have it, you always have it. It doesn't mean you always need medicines.
Okay, so a diabetic coma.
Right.
Is that same thing what you call a DK?
Right. So DKA is a condition where it's a really acidic state in the body, and it affects your mind, your mental status, and you go in the hospital and you can die from that. If you don't get to the hospital in time enough, you can die. And I've had patients that have died from DKA. You know, you get them in, you try to get them aggressive IV fluids, you try to get, insulin drip, you put them on, you try to do all these different things. Sometimes you even have to put them on the ventilator to try to help blow that extra acid off of their body. But again, it's a very, very worrisome condition because you never know where that person comes in. The other complicating factor with DKA and giving the aggressive IV fluids is that the person has congestive heart failure, you can't get but so aggressive with giving the IV fluids. And to correct DKA, you have to give the insulin to correct the sugar problem, and you have to give the fluid to correct the dehydration. Those are two things that you have to do when that person's in the intensive care unit when DKA, or what people call a diabetic coma.
Say, are people religiously listening when you tell them what they got to do, since now it's been discovered that they have diabetes, and warn them and all that kind of stuff? Will they follow the diets?
I think most of my patients do, Brother Edward. So I'm on faculty. I didn't mention this earlier, but I'm on faculty at MUSC as well, and I get about 5 medical students that come and spend about 2 months with me every year. And one of the things that the students said yesterday, it's like, Dr. McIver, most of your patients are well controlled with diabetes. And I said, sweetie, it wasn't always like this. I said, some of these people you're seeing today, we had some knockdown arguments in this office. But again, when it comes down to things like diabetes, I hear the patient and I listen to what they're saying, but ultimately I have to have the final say on what needs to be done. And if that can't be, then that person probably needs to find another physician. Again, I'm not just a physician that treats it, I am a diabetic.
So do you tell your patients that you are diabetic?
Oh yeah, I don't have a
diabetic patient.
Yeah. I don't have a problem telling them that, particularly if it's a certain treatment that I think they need, and they may be a little bit apprehensive about taking medications. I talk to them and I explain to them why. But I also want to hear what their reservations are about it. So that way we can talk it out, we can talk through it. Social media has been a great thing in some ways, but it's been a horrible thing to the medical community in other ways. Mm-hmm. I mean, you got people that's getting on telling people what to do about medicines who hadn't passed the first medical board. You got people that's confusing their YouTube knowledge and their Instagram philosophy with what I do. Yeah, and that's not sounding boastful, arrogant, or conceited, but this is what I do. I can't tell a plumber how to fix a toilet. I can't tell a roofer how to put on a roof. I can't tell a mechanic how to fix a transmission. So I don't expect you to come in and tell me how to do what I do.
Mm-hmm. And Dr. Mack, I'm glad you brought that up, because yes, in the world of TikTok docs and all of the other things that are out there, people are searching for information, especially in this, instant gratification kind of society that we live in. And also, there's enough naysayers out there to instill some doubt in people who really do need to go and visit their doctors and find out more about their conditions. There are people who are like, I don't want to be on the man-made medicines. I've even said that. So they look for things, such as natural remedies and, certain tinctures or potions or whatever.
And I'm okay with some of that stuff in addition to. I take cinnamon. I don't have a problem with cinnamon. Studies have shown that cinnamon can definitely help. So there's certain things like that I think can go in addition to what you need. The ultimate goal is identification, appropriate management, and reducing morbidity and mortality. If you can do the things that we need to do and I can get you off of these medicines, that's my ultimate goal. That's a win. I really don't like writing medicines. If I could go my whole day without writing a prescription, I would have won. But again, I took an oath to first do no harm, and I have to practice evidence-based medicine. In other words, studies, research to back up what I say. Everything I do in this office, I can back it up by study somewhere. And that's called evidence-based medicine. Evidence-based
medicine. Let's get into treatments. We all know that, some of the newest, treatments that are on the scene right now are your GLP-1s, your semaglutides, your Ozempics, and all of that. I don't know if that's a part of what you're going to talk about as far as the advancements, but let's get into it.
You're right on my heels, sis.
All right.
So the first treatment is diet and exercise. The second treatment are tablets, the metformins, the sulfonylureas, glipizide, and those kind of things. Right. The next thing would be the insulins, and we have long-acting insulins, and we have short-acting insulins. So those are kind of been in our armamentarium of medicines for a while. But what's come out recently is two groups of medicines that I get more calls and conversations about than anything else, I think. One is called the GLP-1s. So what the GLP-1s do is so the GLP-1s are the Ozempic, Mounjaro, the Wegovy, the weight loss shots. And I'll get into that part in just a second, but I'm going to talk about it in terms of diabetes. So the way the GLP-1s work is that when the body senses that there's an increase in sugar, it stimulates the pancreas to produce more insulin. Right. So that's how it lowers the blood sugar. Right. But another thing that the GLP-1s do is they curb your hunger. And the main way that it does that is it slows down the emptying of food out of your stomach. When it does that, your appetite is cut faster, you're eating less, and hence you're able to lose weight, particularly if you're doing the other things such as exercising. Now, the main issue with the GLP-1s is that, like I said before, it slows down the emptying of your stomach. So if you sit there and you try to eat the same amount of food that you were eating before you started taking these GLP-1s, you're going to have some problems. You're going to have diarrhea, you're going to have nausea, and you're going to have vomiting. Because if you imagine food just sitting in your stomach, but then you're just putting more food in on top of it, it's going to create a problem. So as long as you can back up and you eat less than what you would normally eat before you went on these medicines, you should do fine. The other part to it is that the physician has to be careful on how fast they escalate the doses. A lot of times patients will come in and they'll want to go from the first one to the third dose in a short period of time. And what ends up happening is that you can have these episodes happen more and more with the GI symptoms. So that's the GLP-1s, right?
What does that stand for? G, L, and P?
Glucagon-like peptide. Glucagon is a hormone that stimulates the pancreas to produce insulin. But for short, in medicine, we use acronyms for everything.
Yeah, I know that.
So it's called GLP-1. Okay. The other part is called SGLT2s. And basically, those are the Mounjaros and the Farxigas. And basically, what they do is they work on, if they notice that your body's carrying a large amount of sugar floating in the bloodstream, it kind of packages that sugar and sends it to the kidneys so that way you can urinate it out.
Right, okay.
So that's how the SGLT2s work. Now, what happens is that the side effect potentially from SGLT2s are yeast infections, because if you're peeing all this extra sugar out, some of that can create yeast infections that happen, or urinary tract infections. Also, sometimes if you lose a lot of fluid, because it can make you pee a lot too, if you take those and your sugars are really high, you can sometimes get some nausea and dehydration as well. But again, if you're drinking fluids, water adequately, that's less likely to happen. So those are the two newer medicines that we use commonly. Now, I get just as many calls from people who are not diabetic wanting to take these GLP-1s for weight loss. The insurances are pretty much not paying for that. So there's some insurances that may have a carve out that may pay for it, but if they don't, these are $1,000 a month. Now, let me take that a step further. There are some of these clinics that have popped up around here in other cities that are giving you synthetic Ozempic, Mounjaro, and Wegovy. The semaglutide, the liraglutide, if it's not coming from your physician and you're not getting it from a pharmacy, leave it alone. Because those synthetics are not the real thing. At best, they're probably 60 to 80% of the real thing. The question is, what the heck is in that other 20 to 40% of that medicine?
That's scary.
So, you know.
So you're talking about Ozempic also?
No. So if you get it from the pharmacy and it's the real thing, then it's the real thing. But there's some of these clinics that are popping up that are giving man-made, generic versions of these medicines. First of all, these medicines are not in a generic form. So there are companies that are pharmaceutical warehouses that manufacture this in a powdered form, and they sell it to a physician where they can give it to the patient for $50 or $100 a month. If I just told you that the medicine costs $1,000, do you think you're getting the real thing at $50 or $100 or $200 a month? It's a knockoff. The problem is those things are only about 60 to 80% of the real medicine that you get from the pharmacy. My question is, what is in the other 30 to 40%?
But if it's effective, then that person really doesn't care what's in the other 20.
They don't care about it now because they're looking for short-term gains. The problem is, what is it going to do to you 10 years from now?
Or even 5.
Exactly. So I'm a big proponent to not do that. And these people are opening up these weight loss clinics, and that's what people are doing. And they're paying this money, but they're paying for a knockoff, which the companies are like really upset about this for obvious reasons. They're losing money too, but they're upset about it because if things happen, then people will come back and try to sue the real manufacturer. And they're like, look, that's not us. That's somebody that's synthetically making this stuff, which is not the real deal. So stay away from those weight loss clinics.
Dr. Mack, I do want to put this question up because I think it's very important. Why is the insurance denying some patients the new diabetes medications?
Okay.
And so, if you as a physician prescribe the medication and they take that medication to the local pharmacy to get it filled, it does seem counterproductive and actually against whatever you're trying to treat in terms of this patient is concerned, for an insurance company to deny someone a medication that you as the doctor has said, this patient needs this medicine. And especially with these classes of medicines that do not have a generic version that is, at a lower cost. And to your point, when they deny, the insurance company denies paying for it, it can mean thousands of dollars for a patient who this might be their last resort or close to their last resort. And I know that there's been situations where, physicians try to carefully write the prescription or the order so that the insurance company doesn't deny it. But why does it happen is the question.
Okay, so good question. So what happens, the first issue that happened was it was a supply and demand problem. You had all these people that were willing to pay $800, $900, $1,000 who weren't diabetic, which jammed up the supply. So then the insurances got stricter and said, look, if this person doesn't have diabetes, we're not covering it. So that's the first issue, writing it for the right person. The second issue is that some insurances have what's called a step edit, which means I may want them to take a GLP-1 like Ozempic, but the insurance will say, look, doc, has this person tried one of the other types of medicines? Can they try that first? Because not everybody really needs Ozempic or Mounjaro or Wegovy. Some people, if they do the right things, they'll be okay with taking Tresiba, or taking another type of shot, which is less expensive and in a generic form. So I get it. It's a business decision for the insurance companies. There are a lot of options, but I typically don't have a problem getting these GLP-1s through for diabetics.
So what is a typical candidate for Ozempic?
A person whose A1C is, let's say, 8 or above, and they're more than, 20 pounds overweight. So that's kind of an idea, but I mean, there are lots of different combinations with that. But I really don't have a whole lot of problem getting GLP-1s or SGLT2s covered for diabetics. The problem is that if the person's not a diabetic, the insurance is likely not to cover it. So again, there are a lot of options out there for diabetic treatment. And I'll go back to the SGLT2s for a second. There was a couple studies that were done on both Farxiga and Jardiance that showed that not only did it help lower A1Cs, but it also helped protect the kidneys and the heart. So now you have just as many cardiologists and nephrologists writing for Farxiga and Jardiance as you do primary care docs. So they don't just help diabetes, they also help heart protection and kidney protection. So that's one of the things about these medicines is that, they've come to help so many people, but, again, the issue was there were so many people who didn't qualify for the medicine, but doctors were still writing for them. Wow. So it's mainly a supply and demand issue.
So the supply is short, is it?
Yeah, the supply is short. Last year this time we had to take a number of patients off of Ozempic and Mounjaro because they couldn't get it.
Couldn't get it.
And you substituted with what?
Well, another injectable. It depends on the person. It depends on what the A1C was. It depends on an individual picture that I have for the patients.
Right.
Yeah, it's a pretty serious situation, when it comes down to this class of medicine being highly effective, patient being on this medication, and then the supply chain freezes up or, whatever the case is, and you can't get it. Because then, there's, and I've heard of cases from just people that I know who are like, and then I had to switch to a different medication or a combination of medications, and it just did not work for me. Like it wasn't as effective as this class of medication, or they had some other side effects from what they deemed to be the switch up. Like I wasn't experiencing this kind of stuff until I switched to this medication. So it's a really serious situation, Brother Eric. But unfortunately, it's taking the Ozempics and the Mounjaros and the Wegovys of the world have become glamorized,
right?
And
$1,000 a shot. I mean, you're right.
Yeah, $1,000 a month.
I'm calling the month a shot. Yeah, time. Yeah,
a month. Yeah. So, but this is great information. Is there anything else that's on the horizon in terms of diabetes treatment?
Yeah. So there is. So I want to make sure that I left with some of the advances in diabetic therapy. One of the things is the type of insulin itself. So back when insulin was first created, it was created from animal sources, cows and pigs. And those weren't really physiologically compatible necessarily to a human. So now with the synthetic insulins and things that are being made, it's more physiologic to work the way our pancreas typically would normally work. So that's been a big advancement to try to help get sugars controlled better. Another thing is
the pancreas. They're messing with that too.
Oh yeah. So the insulin that the body creates comes from the pancreas. There's cells in the pancreas called beta cells. And once the beta cells stop functioning appropriately, the body starts to produce less insulin. And that's what creates the issue where you may have a person who may have started on tablets for diabetes, and eventually the tablets seem to lose their punch because the beta cells in the pancreas aren't producing the insulin, and then you have to give that person insulin. That's why a lot of people progress to insulin.
Right. Recently, I had a education on the difference between insulin sensitivity and insulin resistance.
Mm-hmm.
And so, when you weigh sensitivity versus resistance, which one is typically the one that you can actually kind of counter, I guess, more quickly or in a better way? Or is there not, a better way? Sensitivity. Okay.
Because a lot of times weight reduction, dietary exercise can help with the sensitivity, but the other way is just you have to take insulin at that point in time.
The resistance. Mm-hmm.
Resistance,
okay.
yeah.
Okay.
Yeah. Okay. Other advancements, the insulin pumps have gotten better for those people that are candidates for insulin pumps. They're what's called brittle diabetics. I can treat 95% of diabetics that walk through my door. 95%. There's going to be a 5% that I can't touch because those people need to be on an insulin pump. So on those patients, I send them to an endocrinologist. So what happens is the insulin pump is an implantable lead that's into the abdomen area. It senses, so sensitive that it senses where the sugars are, and it tells the machine how much insulin to give at that point in time.
So that's
those are insulin pumps. But they've gotten a lot better and a lot more advanced in the last, 20 years. Also, there's things called continuous glucose monitors, the Dexcoms and the Freestyle Libras. Basically, it's an insulin device that most people usually wear on their arms. And what it does is it takes your sugars and it tracks them every minute. And so you can pull a device up, whether it be a reader that you have, or you can actually download this stuff to your phone, and it'll tell you exactly where your sugars are. Right. So that way, if I ate this, then I've got to be careful eating that again because it may spike my sugars up. Or if you start feeling funny, it can tell you if you're having drops in your sugars. So those are called continuous glucose monitors. They have been a game changer. So for those folks that don't have continuous monitors, talk to your physicians about it. I know right now there's a national back order on the Freestyle Libras. Depends on your insurance as to which one is the preferential one for you, based off your insurance, whether it's Dexcom or Freestyle Libra. I've worn both. I like both of them. I think they do good, and they can kind of help modify, what you're eating, what you're drinking, and that kind of thing. Okay.
I have to ask Dr. Matt, because I'm not on a continuous glucose monitor. I don't have one on. Does it hurt to install one of those? Okay.
It does.
Because I don't like to be pricked. I don't like the needle.
It hurts, but it does not.
Nobody likes a needle.
No, me especially. I will fall out on you with the needle. Okay.
It's a game changer. And again, the adhesive on the patch that stays on, it's good because you can get in the shower with it and it'll stay on. I go swimming with mine and it doesn't come off. And so it's very good, but it kind of gives you a continuous reading on where your sugar is, so you'll know where it is in real time.
Mm-hmm. Okay. That makes me feel better.
And it beats pricking your fingers too.
Yeah. Oh my gosh, don't talk about that. Yeah. Yes. Mm-hmm. Mm-hmm.
So, other things that have been on the advances have been genetic breakthroughs, identifying some genes that can kind of be associated with certain conditions that can go along with diabetes, but that's still in research type stages. Certain medicines to help. There's one that's being studied right now to see if it can reduce the incidence of ketogenesis. Now, what ketogenesis means, without getting too technical, is you going into the DKA, the diabetic coma. They're doing research on promising medications to help reduce that gene that can lead to DKA. So that's one thing that's on the horizon. And also, one of the most exciting things, which probably will be more of a breakthrough for either type 1 diabetics or late stage type 2, is actually regenerating beta cells in the pancreas. There's a lot of research that's been done on that, about beta cell regeneration, to try to increase the number of beta cells in the pancreas, which could in turn increase your body producing more insulin. So all those things are really on the horizon, on the cutting edge. And at some point in time, hopefully in my lifetime, it'll be something that'll be commonplace to try to help curb the morbidity and mortality of diabetes.
Yeah, Dr. Mack, I don't know if you've ever heard of the Wake Forest Institute of Regenerative Medicine, but
yes,
so
very good place.
Very good place.
Bowman Gray School of Medicine.
Yeah, absolutely. And so I have some colleagues there, and it's amazing. It's almost like sci-fi type of amazing what they're doing at W Firm. And one of the conversations that came up most recently during a program that I attended was, it leaned into what you just talked about, which is all about being able to find some advancements or some regenerative medicine that will help people with diabetes. I don't know if it's about regenerating a pancreas or anything like that, but definitely, the cell regeneration that you're talking about is something that I'm going to ask about whenever I speak to my colleagues again to see if there's anything on the horizon, because that is cutting edge medicine. And it's just fascinating some of the things that they do at that particular institute. I just want to mention that.
Yeah, Bowman Gray is a great place. It's always been some leaders of the pack, and they do a really good job there.
Mm-hmm.
I knew some people that trained there, so very, very good place. But those are some of the advances in diabetes that's looked at. It is definitely, like I said, $413 billion a year is spent on diabetes and diabetes-related illnesses, diabetes-related supplies, work hours lost, all that. All that comes apart in the total cost and lost wages associated with diabetes.
Well, Brother Edward, I'm telling you, wow.
Yeah.
This has been, a very enlightening and powerful education that you've given us tonight, Dr. Mack. And you've done it before, but, seems like every time you come on, we learn something new, or, there's something rich to add to the conversation, because it is a continuing conversation. And so we definitely want to thank you for your time tonight. And want to say thank you to all of the viewers who tuned in tonight. There was, one viewer, JD Spain Jr., he recommends there's a show on Netflix. And so if you read in the comments, you can see more about what he's talking about. But, even still, this information is so powerful. And if it doesn't apply to you, meaning, any of the viewers or listeners tonight, I'm sure there's at least one person who is dealing with diabetes. I'm positive. And so, or, they're pre-diabetic and they're just trying to figure out what they can do. So, pass along this information. This broadcast is available on wcmagazine.net. It's on our YouTube channel, which is WCM Live, along with a host of other shows that we've run in the past, including ones with featuring Dr. Mack. And so, we can't do enough to educate the community, especially the African American community, because these are things that we typically, like you say, we'll shy away from. We don't want to know. I don't want to know if I'm sick. I don't want to know if something's going on with me. There's some intrinsic fears that we have that come from places and people who are long gone, or experiences that we've had in the past. And now it's time to break the cycle of fear when it comes down to, getting treatment for things, especially diabetes, since it's so prevalent in our community. So thank you so much for being here tonight. We really appreciate it.
No problem.
And I'm sure we'll have you back to talk about some other stuff later.
Okay.
So stay healthy, man, and keep on messing, because we got to have you back with more research.
I'm listening, and I'm listening to myself, and I'm listening. I'm doing what I need to do.
Yes.
So trust me, I got. I am. I'm doing it.
There is one thing I do want to ask you about before we actually close out tonight, and I think it's something that you mentioned, and we didn't really dig into, but stress is a real killer, right?
Oh, definitely.
Stress is very detrimental to your health. And I know people are like, wait a minute, he said that stress can cause diabetes, or could be a factor in diabetes to aggravate it. Talk about that a little bit more.
So let's talk about it. The stress hormone in the body is called cortisol. Cortisol is produced from an organ called the adrenal gland. The adrenal gland is the shape of a triangle, and it's right on top of the kidneys. The adrenal gland during stressful times will produce more cortisol. Cortisol is the body's naturally occurring steroid. Steroids will increase blood sugars, hence the domino.
Yeah.
Wow.
So, I also hear that the steroids have a negative impact on bones.
Well, long-term
growth.
high dose, but there's certain conditions that steroids are indicated and you need to have steroids for. I tell people all the time, steroids are one of the greatest medicines ever created, but it can also be one of the most dangerous ones if not taken appropriately in the right way. But again, there's some conditions, certainly some lung conditions, where people need to take steroids, and that's a part of the treatment. Lupus, sarcoidosis, certain advancements in that, they need steroids. But again, it's the high dose long term that you get concerned about. But in this situation, what you're talking about, April, it has to do with the adrenal gland and the adrenal gland producing excessive amounts of cortisol. Cortisol is the body's naturally occurring steroid.
So it's safe to say that people definitely need to be intentional about keeping their stress levels down.
Definitely.
Not just if you're concerned about diabetes, but just in general. And I know it's hard with everything.
It's not easy to do.
It's not with everything that we have to juggle, but
And that's where the exercise come in, because exercise help reduce cortisol levels.
Yeah.
And so again, that's the connection there with the exercise.
I tell you, Brother Edward, the more we dig, the more Dr. Matt comes with that good stuff. We appreciate it. We definitely want everybody to stay healthy or get healthier, and
absolutely.
do all that you can. Knowledge is power. So again, take this wonderful information. Hopefully, it applies to something that is plaguing you right now, but if not, pass it on. Vonda Cookie Vandross Brown out of Columbia, South Carolina. Thank you for watching tonight, Cookie. She says, that needs to be a topic next time, Dr. Mack. Let's talk about it. Stress,
Tell my cousin for her, I'll do it.
Yep, we got to bring you back for that. I think everybody needs it. So, but thank you everyone for tuning in tonight, and especially Sweet Tea. She asked a lot of questions tonight and gave a lot of comments, and she said happy holidays. And we definitely want to say happy Thanksgiving to those of you who observe the holiday. This is one of my favorite times of the year because it's all about family, friends, and food. And, of course, Dr. Mack has talked about, the effects of your diet. So eat in moderation, enjoy yourself, enjoy your family, and all of that good stuff. But more importantly, just, find your reason for giving thanks and just celebrate life. And so we do appreciate everyone being with us. Brother Edward, do you want to mention who's going to be on the show on the 3rd?
On the 3rd. We're going to have Reverend Richard Williams, and he's going to talk about new strategies that's been very, very successful. And he gave a number of about 358 young elementary age people that were successful at bringing up, I believe it was bringing up reading scores, I believe.
Okay.
And he works for the United Way, and he's gotten very well known among himself. And there's another regional channel that wants him to come on a regular basis to talk about what he's doing there over at United Way. So
that's awesome.
Yeah, and he has a lot to say. He always has a lot to say.
Doing good work.
Right. Well, he's a good person.
Yes, absolutely. All right.
Yeah, Brother Edward. One more thing, Brother Edward. Please tell Miss McQueen I said hello. Okay.
She's looking. No, she's can't get it right now. She's looking at the other TV. Probably.
April. I tell Brother McQueen I like him because I love Sister Joella.
All right, that's it. I hope he knows that. If you didn't know, now you know.
First thing he says,
she is the queen. She is the queen.
I'm walking in his office. That's the first thing he says. I mean, he doesn't say, Brother McQueen, how you feeling today or something like that. I mean, you know, kind of pushed me aside. I mean, I look at I'm the patient.
Look, he'll get to you. He'll get to you. Okay.
I'm the patient.
Yeah, he's got to handle more important things first. He'll get to you. Mm-hmm.
Gotcha.
But it's always a pleasure to have you here, Mac. And
No problem.
big time.
No problem. Thank you all for having me. Like I said, anything I can do to help to put the message out, the increasing health, wellness. That's what I do. That's what I am. That's what I do.
Well, we realize we got a gym in the community, and everybody needs to know that. I'm sure most people know it. Anyway, so we'll do what it takes to make sure that the gym is secured and not going anywhere.
I appreciate that.
All right. Well, until next time, everyone have a safe and happy Thanksgiving. And we will tune in. We'll actually be here again December 3rd, Tuesday, December 3rd, 7 p.m., same time, same bat channel with Richard Williams. And we hope that you all will tune in, spread the word. If you want to see the playback of this broadcast, please go to wcmagazine.net. And again, pass it along. It can save a life. So thank you all so much.
Yeah. I mentioned that I don't know if everybody's seen the latest issue, but I should have had it. Should have sent it to April. April could have uploaded it, but you know,
Diabetes Awareness Month.
The website. Yeah, you can go to the
website.
website.
It'll be on the website tonight if you want to take a look at the e-copy.
Right.
All right. Well, Brother Edward, take care, and tell Sister Joelle I say hello as well.
Absolutely. And my brother, I know he's doing well. Can't wait to Thanksgiving.
Yes, he is doing well, and he loves to eat. So Thanksgiving, one of his favorite times of the year. So I'm sure he can't wait. Yeah.
Okay. All right.
Yeah.
So to our audience, thank you all for viewing tonight's program, and certainly appreciate your time and viewing. I know you had other things to do, but with this kind of information that we bring out to you, hopefully it takes precedence over whatever you had to view. Okay. Anyway, Godspeed.
Right.
See you all next week.
Take care. All right. Have a good night.
Thank you for watching the World Community Magazine's Hour of Power Live on Facebook.